Hello, everyone, and welcome to our webinar today. Brandy with the association is not going to be able to join us, at least at the beginning of the call. She possibly will be joining us later. We're today going to discuss specifically home health and hospice updates, waivers, etc., that have occurred over the last few weeks. Specific to COVID-19 relief, we are going, as I said, to address both home health and hospice. They're separate of sorts, but they are going to be addressed individually, but throughout the presentation. We're also going to talk about some billing issues that we have seen of late, some related to PDGM specifically, but helping, of course, to provide information that will possibly keep the cash flowing. So we're going to go ahead and get started. If you have questions today, you'll need to hover your mouse over the bottom of your screen, and there should be a Q&A box that pops up. That's where I will be taking questions. Please don't hesitate to type in those questions as we go through the presentation, and at the end of the presentation, I will be happy to answer all of those questions. So we're going to begin today with the 1135 waivers. The 1135 waivers for both home health and hospice, beginning with home health. These waivers for both home health and hospice have been made retroactive to March 1st of 2020. The home health specific waivers include that the request for anticipated payment, or the RAP for home health, CMS has given the Medicare Max the right to extend the amount of time that they utilize to cause an auto cancellation on the RAP. So when we bill RAPs to the Medicare system, once it's paid, 90 days basically from the first day of the 30-day payment period in question, that RAP is taken back, money taken back, etc., if the final claim has not been filed. So they've given them the time period, or given them the permission, I should say, to extend that time period. We know for sure that Palmetto GBA has said they are extending theirs to be 90 days following the date the RAP is paid, which is pretty substantial as far as number of days beyond what it is today. You will need to check with your Medicare Max to ensure exactly what they are extending it to, and the Medicare Max have been given permission to make those decisions themselves as far as what criteria they use for the extension and how long the extension will be. The OASIS, there are two different components to the OASIS and what waivers they have given, at least for this screen. The initial start of care comprehensive assessment, they have given us the allowance of extending the completion time for that from 5 days to 30 days. While that is quite generous, the problem here becomes the reality that the start of care OASIS, as well as a few others, and we'll talk about those when we get there in a few minutes. But for now, the start of care assessment is tied to payment, and is specifically tied to both the RAP and final claims. And without that start of care assessment being finalized, the request for anticipated payment cannot be billed because we cannot get a HIPS code. So when we talk about cash flow crisis, which some are already experiencing directly because of PDGM, it has been exponentially increased because of the COVID-19 crisis, especially in some really high intensive areas, meaning high areas of infection from the virus. So we want to be able to get as much billing as we can out as quickly and effectively as possible And without these clinical documents being completed, there's no chance of that happening. And then we have the OASIS transmission waiver. Without the waiver, there is a 30-day requirement for the OASIS to be transmitted within 30 days of the completion date on the OASIS. That 30-day submission requirement has been completely waived under these waivers. While, again, that is awesome and generous, we have to ensure that the OASIS that is impacting the calculation of the HIPS code for PDGM claims payment is transmitted and accepted at the OASIS database before you bill the final claim. This is honestly one of the biggest issues we are finding in return to provider status or T-status claims under PDGM, really having nothing to do at this point with COVID-19, but simply that agencies are not ensuring that the OASIS has not only been exported out of your EMR, but effectively transmitted and accepted at the OASIS database prior to billing the final claim. Another part of these 1135 waivers for home health includes that the initial assessment of a home health patient can be conducted via telehealth. Please understand there is a difference between the initial assessment and the comprehensive assessment. It has been a bit confusing because most home health agencies meet both criteria for the initial assessment and the comprehensive assessment during the same visit when they go to the home within 48 hours to conduct the comprehensive assessment. The 48-hour requirement technically is connected to the initial assessment, and the initial assessment is basically assessing the patient for clinical need at the time, ensuring they meet the home health criteria, and in this day and age, more specifically ensuring that the patient agrees to allow you to come into their home. Having said that, because if the patient is not going to allow in-person visits, you will not be able to admit them to home health under the current situation. So the initial assessment can be done via telehealth. The comprehensive assessment must be done in person. So the strong suggestion is that if you get a referral for a home health patient today, that initial assessment is done via telecommunication to ensure, again, primarily that the patient is going to agree to allow you into their home. There have been so many refusals, and because of that, a huge spike in the percentage of LUPAs that home health agencies are experiencing. And so while we are strapped and are having a difficult time in some areas of getting patients taken care of, we sure don't want to waste our time and energy going to a patient's home to admit them only to discover upon arriving at their home that they refuse to let you in the house. So we need to take care of that, begin in person to do the comprehensive assessment. So I had someone ask a couple of days ago, if we have this time to complete the comprehensive assessment, can we meet that initial assessment requirement via telehealth in the first 48 hours and then still have 30 days to go do the start of care? Well, technically that's not the deal. The 30 days is you have 30 days to complete the start of care assessment after the start of care or comprehensive assessment has been initiated. You don't have 30 days to complete it from the referral date or from the initial assessment. You have 30 days to complete it once it has been started. And my question to that person also was, if you get a referral and establish the patient has skilled need and you don't go admit them until 21 to 30 days later, how is that any make any sense in the fact that if they have that skilled need, you're waiting 3 weeks to admit them and meet that need. So it's imperative that we understand the difference between that initial and comprehensive assessment, that comprehensive assessment be in person. You do have 30 days to complete it once you have initiated it, but also, again, knowing that you absolutely have to have it completed, finalized, so you can get a HIPS code and bill the claims. The home health aide supervisory requirement has been completely waived during this time. You are not required to do home health aide supervisory visits at all during this emergency. They are recommending that there is some monitoring of the supervisory situation for home health aides via telehealth, but it is absolutely not required. The same is true for hospice. The last bullet on this hospice screen, hospice aide supervision is not required during this public health emergency. Also included in the 1135 waivers for hospice is that hospice will not be required to provide any services via volunteers during the emergency. Non-core services for hospices have also been waived, including non-core services such as physical, speech, and occupational therapies. The comprehensive assessment for a hospice patient is required to be updated every 15 days. This 1135 waiver is extending that to 21 days. However, they did not extend the number of days for you to update the plan of care. The plan of care still must be updated every 15 days. There has been some concern, and the National Association is definitely working with CMS on several additional requests on top of the waivers we have already received. And one of those is that they extend the plan of care at least to 21 days, but they're really requesting that they extend both of them past 21 days as far as the amount of time that you have to complete the updates to the comprehensive assessment and to the care plan. Hospice aide supervision, as we've already said, completely waived. The quality reporting program for both home health and hospice has basically been put on pause. For home health, during the time periods that you see on the screen, you will not be required to submit HHCAHPS or OASIS technically. So any documents, including patient assessment and HHCAHPS, that would go into the calculation for quality reporting programs is not required to be submitted during the time periods you see on the screen, making a very, very detailed note to yourself that right now these waivers only extend through June 30th of 2020. July 1st, you would have to resume transmission of the required data unless they do extend these time frames a bit longer. Understanding again that for OASIS purposes, while the quality reporting program will not be using OASIS data and technically not requiring you to submit during this time, the OASIS that has to do with the HIPS code would have to be transmitted prior to billing. And that definitely includes the start of care and the follow-up assessment, technically recertification assessment. But if in a 30-day period you had a significant change in condition that required an other follow-up, or you had a resumption of care that you wished to be associated with the coming 30-day claim, you would need to have those transmitted before you bill those final claims. So just keep that in mind. The hospice, or this actually is value-based purchasing for those states that are in the value-based purchasing model. There are 9 states that must participate in this. They are waiving the new measures that have to be submitted via the value-based purchasing portal through June 30th as well, because of the fact that you are relieved from submitting your CAHSAH data and the quality reporting data, both of which are used to calculate value-based purchasing outcomes. They will not be making calculations for value-based purchasing during this time. The hospice quality reporting release includes that the HIS documents and the CAHPS hospice surveys, you have exception to submitting both of those documents during this time. Again, making note that this is only through June 30th, and effective July 1st, you would have to resume unless they make another extension. Telehealth. This has been the touchiest subject, for lack of a better term. While we are thrilled and relieved that face-to-face can be done via this mode and that we have been given permission to provide visits, the frustration is primarily the fact that it is not billable. So let's start with the face-to-face encounter. For home health, they are allowing during this emergency for face-to-face encounter requirements to be met via telehealth. This is for all home health patients that require a face-to-face that cannot be obtained via any other method. It is not just for COVID-19 related patients. So during this emergency, you get a call for a patient that needs to be admitted for CHF that will agree for you to come to their home, but they have not been in a facility, et cetera, and do not have a face-to-face encounter documented. That patient could then have a face-to-face with their physician via telehealth. It is possible, and it has definitely happened, that physicians have requested the home health agency have a representative in the home to assist the patient with the audio-visual needs for this telehealth visit. You cannot, as a home health agency, be reimbursed for doing that, even though you might participate. And so we've had some agencies tell us already that it hasn't been as big a deal, or they haven't had that big a deal with it because of the fact that most of their patients upon referral do have a face-to-face encounter that has already occurred, whether it was in their physician's office or whether they had been hospitalized in a facility, et cetera, and then sent home. They have a face-to-face encounter that meets the requirements as they typically would always have had. If that not be the case, and you are admitting a patient that has not had one, this can be done if, again, the agency is involved. You cannot bill for that involvement. Having said that, some of the agencies that we know that have already had to do this have done so after they got a referral. They have done their initial assessment of patient need, confirmed the patient agrees with home health clinicians coming into their home, et cetera, and then coordinated that telehealth face-to-face encounter with when the clinician would be in the home to conduct the comprehensive assessment and do the initial start of care visit. That being the case, while they're in the home conducting the start of care visit, they assist with the telehealth face-to-face. We've had some agencies that actually say it worked out really well because they were there for the start of care. They provided a billable skilled service, so they were able to actually bill for that visit. In addition to that, we've had some comment that it was actually quite beneficial to be present while this telehealth visit was happening with the physician because they were able to ensure that the encounter was going to include documentation to support the primary reason the patient was going to need home health. Now, some of you are probably screaming at your phone. Some may have already thrown it out the window or turned over your computer monitors thinking she has lost her mind. There's no way that it's that simple. And I get it. I really do, especially trying to coordinate a time with a physician that you would be able to make this happen or work it out. But just trying to give suggestions and tell you for sure that we know some have had to do it already, etc. Now, there is within the release document a comment that home health agencies could receive some relief or some payment, let's say it that way, for assisting a physician if they subcontract with the physician and the physician reimburses the service. Understanding, however, that cannot happen if the patient is admitted to home health. So the only way you're going to subcontract with a physician's office to assist with this is if the physician basically just needs to conduct a visit with the patient and they happen to call your agency to assist with that, not referring the patient to home health. So just make sure you're clear about that. Other telehealth allowances during this time include that telehealth visits may be provided for normal visits that would happen with the patient in home health. However, you must ensure that your plan of care and orders for the patient's care include that those visits are true telehealth visits. You cannot replace ordered in-person visits with a telehealth visit. So if the orders are for twice a week for the nurse to be in the home, you cannot say, okay, well, we'll just go do a telehealth visit instead of sending the nurse to the home. If you provide telehealth visits, they must be in the orders as telehealth visits. And of course, any care that you provide via telehealth must not compromise the patient's care situation and must not prohibit them from receiving skilled care that they need. Because these are not billable, as I've already stated, they will not go on the claim. If they are not billable and on the claim, they cannot be counted in the LUPA thresholds. So we have had agencies asking already, do we just record these as visits in the system? For hospice, which we'll talk about in a second, do we just record them as a routine home care visit? And the answer is no, because they are not truly a routine home care visit. And if you record them that way, they're going to show up on the claim. If you record them as a skilled nursing visit in home health, they're going to show up on the claim. So you need to have discussion with your EMR as to how these are going to be recorded in the medical record. They do need to be recorded. They do need to be documented. What transpired during this telehealth visit needs to be documented. But again, it cannot be that visit shows up on the claim. The HIPAA compliance situation has had some home health and hospices concerned, but do understand there has been a HIPAA compliance relief measure taken at this point, such that it is relieving agencies of penalties, et cetera, that might take place during this emergency, specifically related to telehealth. Having said that, basically that means that there are some softwares out there that have you can hear me, you can see me capabilities, such as the one we're actually using today for this webinar if I had my video camera on, and they may not necessarily be HIPAA compliant. The one that was specifically noted in these relief documents was Skype. And so Skype is not typically HIPAA compliant, but Medicare is allowing, CMS is allowing you to use those forms of telecommunication if that's all you have access to during this emergency, with you being not liable at all for any penalties that might have been given out otherwise due specifically to HIPAA compliance. Also note in bold print on the screen, this relief from HIPAA compliance does not affect HIPAA compliance in any other area of healthcare outside of telehealth. So just because they're saying you can use this device that's not typically HIPAA compliant for telehealth does not mean you can go out and share patient information in any other modality that you so choose. HIPAA compliance is still in place except for the technology involved with telehealth that might not otherwise be HIPAA compliant. All the 1135 waivers, et cetera, during this public health emergency will be active until it has been officially declared that the emergency has ended. Telehealth for hospice includes that the face-to-face requirement can be met via telehealth, just like with home health. This again does include all patients, not just COVID-19 related patients that are in hospice. This visit must be conducted by an allowed physician or nurse practitioner, the exact same application as the hospice face-to-face if it were to be in person. So the physician being your medical director or member of your IDG, a nurse practitioner that is either employed by the hospice or a volunteer. Physician assistants still cannot currently conduct face-to-face encounters in hospice. The technology must be a two-way audio video capacity for the face-to-face encounter itself. And basically that is true for home health as well. Understanding that basically just means the patient can see and hear the physician can see and hear the patient. Routine home care visits are also allowed during this time to be conducted via telehealth for hospice. However, those visits, just as with home health, must be documented in the care plan of the patient that they will be conducted via telehealth. Now, we have learned or been given firm clarification from CMS that the routine home care visits conducted via telehealth and hospice can be conducted using a telephone only. The routine home care visits do not have to have video. So that is a consideration, but most importantly, any telehealth visits conducted in hospice cannot jeopardize patient care or affect the patient's health risk at all. Also, we had someone ask on the CMS call yesterday if routine home care visits are conducted via telehealth during the last 7 days of a patient's life, can the hospice record those visits on the claim and them get counted in the SIA calculation? And the answer was no. Routine home care visits conducted via telehealth are not to be reported on the claim. Hospice, of course, is paid per diem. Additional reimbursement per visit couldn't happen anyway, and again, should not be on the claim. Homebound status for home health patients. Due to the criteria or the current emergency situation, any patient that is considered to be of years, for lack of a better word, your Medicare patients, if they are due or if they are eligible to Medicare due to age, are going to be 65 years or older. In addition to that, if you have a patient that is eligible for Medicare that is not that age, that patient typically is going to have underlying health conditions that would make them at high risk if exposed to COVID-19. Because of those two categories, being in the very category that they have suggested self-isolation at home, and so they would not come into contact with COVID-19, basically they meet the criteria of being medically contraindicated for those patients to leave home. So because of that, CMS has basically said patients that are in those age groups, have underlying conditions, all considered to be medically contraindicated for them to leave home, exposed, suspected of being exposed, or simply meet the criteria of age and high risk, are basically going to be considered homebound during this time. So don't stress the homebound thing. If the patient's 65 years or older, during this emergency, you pretty much have a homebound considered patient. You obviously need to document the situation, especially if the patient is found to be at risk for having been exposed, or if they have been confirmed as a COVID-19 patient, which we'll talk about in a few minutes. They have pretty much guaranteed that there is not going to be survey deficiencies or medical review denials, penalties, etc., during this specific date parameters, which obviously the entire date parameters have not been identified at this point, but don't stress the homebound status thing. The next thing we're going to discuss is non-physician practitioners in home health. Under the current statute, only a physician, MD, DO, or DPM can certify patients for Medicare for home health services and sign orders. Due to this public health emergency, as Congress was passing the CARES Act, it includes the legislation that the home health industry has been trying to get passed for 13 years that would permit non-physician practitioners to certify and order home health services. This, of course, is limited to what is allowed in your state. I know for a fact that in the state of Tennessee and the state of Missouri, currently state law does not allow for home health agencies to permit non-physician practitioners to certify or order home health services. With state intervention of temporary relief, et cetera, home health agencies in those states or any other state that has this problem would be able to then function under this relief. I do want to make sure we are very clear that this legislation that was passed is truly legislation that has changed home health basically forever. What we want to believe is forever anyway, right? And again, something we fought for the last 13 years. And so even in the CARES Act itself, it states that CMS could take up to 6 months to make this permanent. So the reality is CMS will have to go through rulemaking changes in order for the Medicare rules for home health to include that agencies will be able to accept orders and certifications from non-physician practitioners. But in the meantime, CMS has accelerated what they call the non-enforcement policy. And so CMS has a list of things that they have basically at their fingertips that if applicable in a time of disaster or emergency, they are able to provide non-enforcement policies about those particular things. And one of those is non-physician practitioners. So now that Congress has passed this legislation, CMS accelerated the implementation by saying during this time period, during this emergency, there will be no deficiencies, there will be no penalties, there will be no denials for home health services because a nurse practitioner, PA, CNS certified and signed orders for those patients. So basically what they're saying is we're going to ignore the requirement of an MDDO or DPM during this time of emergency. And then they will eventually have to make it permanent. They don't have a choice because of the fact that the legislation was passed. I expect that at a minimum, it will be in the proposed rule that should be released in July for 2021 implementation, and it would be in effect January 1st. Now, that's just Melinda talking. That does not mean by any means that's what's going to happen, and the National Association, NOC, is definitely pushing for them to accelerate that rule-making change so that it can become permanent sooner than later. This did go into effect March 1st, so it will be only for dates of service, March 1st, 2020 and later. Also understanding that we have had several ask, if you already had a patient on service that was certified by an MD, DO, et cetera, but you still have outstanding orders for those patients, would you be able to get them signed by a nurse practitioner, PA, et cetera? And the response that we're getting is if the patient has been certified by a different physician, that physician would have to provide an order stating that you are allowed to accept orders from the nurse practitioner, PA, et cetera. If it is a brand new start of care or a new recertification of the patient, you will be able to use non-physician practitioners to certify at the start of care or recertify at recert and carry on with all orders with no physician MD, DO, or DPM intervention, and absolutely no co-signatures are required. And again, hoping that that's going to be permanent sooner than later. From a medical review standpoint, targeted probe and educate has been halted. In fact, the language in the relief document also say that, well, basically what it says, it's actually in the frequently asked questions where they say this, but what they say is the MAC ADRs, so the Medicare MAC ADRs, which now can only be targeted probe and educate, SMRC audits, and RAC audits are all halted without question or hesitation. However, they do say that fraud investigations do not cease. And so typically, if you're under an OIG audit or you're under a UPIC audit, which used to be called ZPICs, if you're under a UPIC audit or an OIG audit, they would not cease those audits. So if you had received a letter, home health or hospice, that you were on targeted probe and educate and they had requested charts from you, if you had not sent in those charts when this went through in the middle of March, you should have now been taken off of targeted probe and educate. Well, not taken off, but halting them requesting charts, and any of the claims that they had requested an ADR for that they had not received your chart to review, they would have released that claim to be paid. If they had accepted your chart already, so you had submitted the documentation needed for them to medically review it, they will be reviewing those charts and returning a response accordingly. Our understanding at this point is once this public health emergency is over, they will resume where they left off as far as the targeted reviews, SMRC audits, and RAC audits are concerned. Now, the touchy subject comes with the review choice demonstration, and with this being an Oregon association-sponsored call, I'm not going to elaborate a lot here because I know that you guys are not in an RCD state, but the review choice demonstration is active currently in Ohio, Illinois, and Texas, was set to be implemented in Florida and North Carolina in May, on May 4th specifically. They have, in the form of this relief effort, said that RCD absolutely will not start on May 4th in North Carolina and Florida, and have told them basically they don't know at this point when it will resume. So I'm sure they'll be given a warning after this emergency is over, and then it will begin. For the ones that are currently in Ohio, Illinois, or Texas, if they are under the pre-claim review portion of RCD, which basically means they're having to send in documentation at the beginning of the 30-day payment period to get a unique tracking number to go on the claim, they are being told that they can pause that for their agency during this emergency. However, Palmetto GBA is currently sticking to their story of saying that if the agency chooses to pause during this time, all of their final claims that are billed without a U-10 during this time will be subject to 100% ADR review. Well, all of that is just ludicrous. They need to pause it completely and resume it just like they're doing targeted probe and educate when it's over. Even if they ADR review these charts after the fact, if there's nurse practitioners that signed them, they can't count that against them. The homebound status has basically been relaxed. What are they going to do about that? I mean, I could go on and on forever. So NOC is really working hard to get CMS to back off this, but for now, that's the story we're being told. So the COVID-19 diagnosis coding situation, the diagnosis code went into effect April 1st for COVID-19, which is U07.1. That is if the patient has received a confirmed diagnosis of COVID-19. If you were to Google diagnosis codes for COVID-19, the first link that came up, at least when I did it, was the World Health Organization. And the World Health Organization site tells you that there is two codes, U07.1 and U07.2. However, if you keep digging and investigating, as I had to, you will find that U07.2 is not a diagnosis code that is included in the code set for ICD-10-CM. There are two sets of diagnosis codes, ICD-10 and ICD-10-CM. ICD-10-CM is used in the United States, and only the diagnosis codes that are in that code set can be used here. So U07.2 is not an option. U07.1 is the only one to be used in the United States again, and should only be used if the patient has a confirmed diagnosis. If it is the primary diagnosis of the patient used in home health, it would be grouped, the patient would be grouped into the MMTA respiratory clinical grouping under PDGM, and the case mix weight and corresponding reimbursement that would normally calculate for MMTA respiratory would be the calculation. If COVID-19 has been confirmed and the diagnosis used, but it is not the primary focus of the home care episode, COVID-19 can be coded as a secondary diagnosis, in which case it has been placed into the low comorbidity categories. So if it were the only diagnosis, secondary diagnosis, that would give you a comorbidity adjustment, you would receive a low comorbidity adjustment for it being a secondary diagnosis of your patient. The diagnosis code U07.1 went into effect April 1st. So any dates of service prior to that, you would not be able to use the diagnosis. Also, the grouper for PDGM on the CMS website was updated and went into effect for the claims processing system on April 6th, which was this past Monday. The grouper itself was put up on the CMS website on March 31st. RAPs and final claims should now be allowed to process for payment with COVID-19 as the primary diagnosis. EMRs are going to have to update the codes within their own systems in order for you to even be able to use COVID-19. Hopefully most of them have already done that, but I honestly had a conversation with a software vendor 2 weeks ago that had still not updated their code set for the October 31st changes that occurred with the home health final rule. So nothing would surprise me. But you'll need to make sure your EMRs have those codes, have that code included in their system. For hospice purposes, same as with home health, it did go into effect April 1st, and it is allowed as the terminal diagnosis of the patient or primary diagnosis of a hospice patient, but again, could also be used as secondary. The next screen talks about the advanced and accelerated payments. If any of you participated in the NOC town hall meeting today, there was grave detail about this accelerated payment program and some other loan programs under the Small Business Administration. If you were not on that webinar today, that town hall call, positive they recorded it, and you should be able to get that through the NOC website. This Advanced Accelerated Payment Program is basically an advance on your Medicare payments that you anticipate being your revenue for the next 3 months. The CMS has actually made calculations themselves and updated the forms on Monday that you would use to apply for this advanced payment. And the calculations that they have made have basically taken your Okay, I'm going to get it out in a minute. CMS has taken 3 months of your historical data. It has not been absolutely confirmed what period of time they used. Some have said that it was October, November, December of 2019. And as whatever time period they have used, they have established what they believe to be 3 months of your anticipated revenue and are setting that as the maximum amount that you can receive in the form of advanced accelerated payments. So these accelerated payments, the Medicare MACs are supposed to be working to, once they have received your application, reviewing your application, processing your application, and dispersing the funds requested within 7 days of their receipt of your application. Now, the dispersed funds basically will come to you in whatever form they normally pay you, most electronic transfer, of course. And the approval or disapproval is going to be very expeditious. Basically, you qualify if you have billed Medicare in the last 180 days. If you are not currently, your company is not currently in bankruptcy, and you are not currently under a fraud investigation. So if you're not in a UPIC audit, if you're not in an OIG audit, you're not in a bankruptcy, and you have billed Medicare in the last 180 days, you basically qualify. This is the concern that I have, at least. I know that agencies are panicking, some of them at least. Some of the panic is from patients who are refusing care, which is causing the LUPA percentages to skyrocket, meaning agencies that had calculated that their LUPA percentages this year would be 5 or 6% have turned out now to be, just in this few weeks, 20, 25%. Obviously causing a cash flow situation, or at least a revenue situation. Some patients, they don't have the protective equipment they need to treat patients and protect your own clinicians. We could go on and on and on. There are some agencies that are having cash flow problems because they can't get doctors to sign their orders. Well, my issue with that is, if that has always been the trend and remains the trend, is that going to change? Likely not. If you're in a cash flow crisis because your LUPA percentages have increased, patients are refusing care, et cetera, how quickly is that going to turn around or change? My point is, if you request 3 months of advance payment based on October, November, December of last year, and you receive those payments, and then 120 days from now, when they start 100% withholding your Medicare money to pay back that advance that you received, are you going to have the billing in the system to pay back that money? That money has to be paid back in full by day 210. Well, what if we don't have enough billing to do that? If you don't have enough billing to do that, then by day 210, you have to have worked out something with CMS, and interest starts accruing at that point. And it is not cheap interest either. And so while I'm not saying that you should not do this, I am saying that you need to be extremely careful when calculating what you anticipate to be your true monthly revenue for 3 months. You also need to ensure yourself that you have the infrastructure in place to be able to accomplish the billing that is going to need to be accomplished to not only pay back this money to CMS, but get cash in the bank so that while they're taking back all this money, you have additional money that you're going to be able to keep your agency open with. In fact, some may be to the point that that's going to include other means of financing through loans, et cetera. And some of those loans through this emergency actually forgivable through the Paycheck Protection. It's called PPP, and that was also included in detail in the webinar that was conducted with NOC today through the town hall meetings. So regardless of what you decide has to be done within your organization, please make sure that if you take these advance payments, you know for sure that you've done the best you can at truly estimating what your revenues are going to be and have pretty much things in place to know that you'll be able to pay it back without significant interest, without significant burden, and be able to stay open after that point. The Medicare cost reports due dates have been extended. October, November, and December fiscal year ends, as you see on the screen. Due dates have been extended to June 30th and July 31st. Those extensions can change. We get it. We know it. We've seen it happen already. But until you've heard that there is an additional extension, those are the due dates. And hopefully will give you the time to get the adequate information needed to your cost report preparers. These next three screens, two of them home health, one hospice, are the additional requests that the National Association for Home Care and Hospice are working with CMS on to get further relief to agencies. In home health, they are requesting from CMS that the face-to-face encounter be done via telephone only and not necessarily have to have video. They're requesting that non-physician practitioner certification and ordering be made permanent as soon as possible. As I've already stated, they're going to have to make this permanent because it was in the legislation, but at the pace that they do that may be a different consideration. So we're hoping they expedite that. Venipunctures, they're requesting that home health agencies be able to do that as a standalone skill during this emergency. Restoring wrap payments to the 60-40, 50-50 split that we had under PPS. This is extremely frustrating that we were even reduced to 20% with PDGM. And of course, if it were changed back to the 60-40, 50-50 split, be much more advantageous from a cash flow standpoint for agencies, especially since you don't have to have orders signed before you can bill those. Currently, there is a 4.36% behavioral adjustment built into our base rate. NOC is requesting that behavioral adjustment be suspended until this emergency is over. They are also requesting the use of symptom codes as primary if it's a patient that is currently under investigation for being exposed to COVID-19. They are requesting that signed orders not be a requirement for billing final claims. So I don't believe that they're going to give us both, meaning change the wrap payments back to 60-40, 50-50, and say that final claims do not have to have signed physician's orders. I don't think they will do both. My hope would be that they would allow us to bill final claims without signed doctor's orders. If that be the case, there's going to be hundreds of thousands of agencies that would not even have to consider accelerated payments because they would be able to bill the final claims that they're currently holding because they don't have physician signatures. So that is a very deep consideration. The intermittent, skilled nursing requirement that you cannot do a one-time only visit and bill for it. NOC is requesting that CMS allow that. The suspension of RCD, which we discussed a few minutes ago, and the fact that them going to 100% ADR review those charts, insane, and hopefully that will go away. Broad scale settlements of appeals, they're asking that CMS provide settlements on appeals when there are agencies that have huge dollars outstanding waiting for additional appeal review. They're looking to suspend the value-based purchasing demo completely for the year 2020. NOC is working with CMS to request that aid competencies and the 12-hour annual in-services be tweaked, an abbreviated comprehensive assessment. So if you get into the emergency allowances that CMS has at their fingertips, you will find that one of the things they could implement, if they so desire, is allowing agencies to do an abbreviated comprehensive assessment, which would include only the items that directly impact the patient care and the items that affect payment. At this point, we still have to complete the entire comprehensive assessment of the patient, and there is no abbreviated option. But again, they are pursuing that. Currently today, if you get an order for home health that includes both skilled nursing and therapy, nursing has to be the initial discipline in the home. NOC is requesting that during this emergency, therapy be able to go in and do that visit. Telehealth recertification assessments, they are requesting that those be able to be done by telehealth so that home health agencies with patients that are refusing in-person care, while you're not able to bill for the telehealth visit, at least you could have the patient still on service and provide the telehealth services so that you could at least monitor what's going on with the patient and ensure that the best you can that they are okay. Waiving the written information requirement, so any written paper documents that we would have to leave in the patient's home, they're asking for waiver of that at this time, and the one direct discipline rule, which requires that home health agencies have at least one discipline as an employed discipline. The restriction on CLIA, they are requesting that that be relieved so that home health agencies would be able to collect, transport, conduct, and report on COVID-19 test results. And lastly, OASIS E, which is currently set to go in place January 1st of 2021. They are hoping to get that implementation extended and feel strongly that that will happen. For hospice, NOC is continuing to work on the following things: to allow face-to-face to be done via telephone only and not necessarily video involved. Physician assistants be able to conduct hospice face-to-face, and to allow both physician assistants and nurse practitioners to certify the terminal illness of hospice. They're also trying to get telehealth to be allowed for GIP and respite, so that if a patient in hospice is in an inpatient facility under GIP or respite, the home health agency would be able to communicate with the staff within that organization, to communicate with those staff members regarding those patients. Allowing subcontracting of core services versus having to be employed. Allowing additional flexibility in the completion of the comprehensive assessment. We've already said they've already given us 21 days to complete the hospice comprehensive assessment, but they are requesting that be extended, but if not, at least the plan of care being aligned with comprehensive assessment. So both of them would only be required to be updated every 21 days. They're requesting additional flexibilities for GIP, CHC, and respite. The technicalities of what they're requesting there, you would need to review in their list of requests that was included in the NOC report on Friday, April 3rd. The aid competencies, they're requesting that you be able to use pseudo patients for those instead of having to have a live patient, and 12-hour annual in-services be waived. The biggest one, in my opinion, for hospice reimbursement purposes is that they are requesting CMS allow some flexibility in the 5-day window requirement for NOEs to be submitted and accepted. As you see, that bullet point includes NOTRs, or the notice of termination revocation, but there are currently no financial penalties for the NOTR not being filed in that 5-day window, so that's not as big a deal as the NOE, but at this point, 5 days still required for the NOE. They are also requesting that hospices be able to accept a verbal election of the patient versus having to have a written signed election statement. Lastly, they're also requesting for hospice the CLIA release so that hospices would be able to collect, transport, conduct, and report on COVID-19 test results. This screen gives you some links to information specifically regarding these COVID-19 relief efforts. Most of the ones from the CMS website are updated as the updates come in, and they are allowing, so when they're updated, they're actually giving you the date at the top of the screen that they've been updated instead of creating additional documents where this one was this, but now this other document is another update. They're keeping it all together and just giving you the date that it was most recently updated, which is great. These next few screens, I want to talk through some of the billing pieces for home health and talk about one specific thing in hospice that we struggle with in keeping cash moving today. Orders management are these first two screens, and I know you that are specific to home health get the fact that this is huge and that it is the #1 reason why home health agencies can't bill final claims without any relief at all from CMS as far as that requirement's concerned at this point. Those final claims can't go anywhere until you get those signed orders. I need to really emphasize how drastically important it is that if you don't have a control on that situation now, that you take this time to try to figure out what you're going to do before we find ourselves in this crisis type situation yet again. Hopefully that will never happen, but if it were to, that you wouldn't be strapped. I mean, one of the things that definitely needs to be considered if you don't have the capacity already is being able to provide your physicians with electronic signature capabilities. Some of the physicians' offices are not even operating right now, and the physicians could be sitting at a desk somewhere electronically signing your orders. I'm not saying they would have. I'm not guaranteeing you anything, but there is definitely a much more likely possibility that they would be signed more timely if they had the electronic capability of doing so. So something to be considered. You definitely want to make sure that whoever is following those orders, this timeline I get means nothing to you right now. But the fact that somebody needs to continuously and still be on top of these orders is truthfully a reality. You do not need to rely on these 3-month accelerated payment, yet give up on trying to get these orders, because as we've already established, 120 days from now, they're going to start 100% withholding. They got to have something to take that from. So we can't give up the fight in getting those orders back. These next couple of screens take you through what you can and cannot do, or what is or is not required on wraps and final claims. One of the struggles we find within our own clients are the disconnect between the billing department and the clinical department. Clinical people saying, why is the money not coming in? Billing department saying, because you're not giving us what we need to do the billing. And so this gives you some of that. While the OASIS does not need to be transmitted prior to billing a wrap, it definitely has to be finalized so a HIPS code can be created. Currently today, wraps do not require a 5-day timely filing. If the rule does not change before then, wraps will have a 5-day timely filing requirement in 2021. Wraps are currently paid at 20% unless we get that changed. They do not require occurrence code 50, which is required on final claims, and the 18-digit treatment authorization code that we had on PPS claims no longer exists under PDGM. Wraps are required to be in paid status before a final claim will process and pay. And as we said at the very beginning of this call, wraps now have an extended period of time that you will have to get the final claim in before they take your wrap payments back. And wraps are required to have a HIPS code that match the HIPS code that is transmitted on the final claim. This next screen for final claims talks you through the fact that the 18-digit treatment authorization code no longer exists. Occurrence code 50 has basically taken its place, which requires the occurrence date to be included on the claim, and that occurrence date comes from New 90 on the OASIS. That should be in the OASIS database, tying those two together. We'll talk a little bit more about that in a moment. Occurrence code 61 and 62 are the occurrence codes used now to trigger institutional credit on a home health claim. So with final claims, you are required to have the OASIS transmitted, not only transmitted, but accepted at the OASIS database before you bill the final claim. They are going to reprice your claim. Medicare, MAC software systems, the groupers, calculate the HIPS code that they're going to pay you for, regardless of the HIPS code on the final claim. So they have to have the OASIS to do that. Occurrence code 50, as I've already stated, must coincide with the new 90 date on the OASIS in the database. Final claims do not require the 18-digit treatment authorization code. You do have to have the HIPS codes matched between the wrap and the final, and you should have occurrence code 61 or 62 on the claim if you expect institutional credit. The LUPA thresholds are one of the biggest changes that happened with PDGM, of course, other than now having 30-day payments instead of 60. But the LUPA thresholds do range from 2 to 6 visits. Each of the 432 case mix groupings has its own LUPA threshold. If you provide the amount of in-person visits that equates to the LUPA threshold, you will be paid a full 30-day payment for that 30-day, when that 30-day claim is processed for payment. If you provide in-person visits that are less than the LUPA threshold, you will be paid per visit based on the LUPA rate. This is an excerpt from the document you can find on the CMS website Home Health main page that gives you a list of all 432 HIPS codes, the definitions of those, and then in the 5th column, this is the LUPA threshold. So this first patient, if that 30, or this first line, if your patient had bad HIPS code for the first 30 days, your LUPA threshold would be 4, and you would be required to provide 4 in-person visits in order to receive a full 30-day payment. This example, I'm not going to read through the whole thing, but basically outlines a patient situation, giving you both 30-day payment periods that would be calculated at the beginning, where the first one has a LUPA threshold of 5, the second one has a LUPA threshold of 3. You would have to meet both of those thresholds individually within those 30-day parameters in order to be paid full 30-day payments. The cash flow situation, I do not have to share with most of you the fact that it was dire for some agencies even before COVID-19 happened. As you can see in the illustration, last year a $4,000 60-day episode would have resulted in a $2,400 wrap payment in the first 10 days, assuming, of course, that you billed timely. Where the PDGM situation, if you had 32 30-day payment periods worth $1,800 each, both of their wraps would only total $720. So significant issues with cash flow there for some agencies especially, and not being able to get those final claims out has made it even worse. So again, cash flow considerations with the accelerated payments and loan possibilities if necessary. These next 2 screens are basically the billing situations that we encounter most that cause issues with claims for home health right now. It is the OASIS issue. My company does billing for home health agencies all over the nation, and one of the biggest reasons that we are getting T-status claims or return to provider claims today, the biggest reason, not one of the, but the biggest reason, is because of the OASIS either not being in the database or the information on the OASIS does not match the information on the claim. So I really want to encourage you to ensure that whoever is reviewing to ensure that OASIS is in the database is looking at the final validation reports that result from OASIS transmission, and they are not trusting the computer system to tell them the OASIS is okay. If your system simply exports to the hard drive, and then you're responsible for transmission, your software system is marking that claim ready to go the moment you export that OASIS file, but that doesn't mean it's gone anywhere. So you need to make sure you stay on top of that. For hospice purposes, biggest issue we have right now are situations where the patient is being discharged live from the hospice, and that paperwork, et cetera, is not happening quickly enough. Because of that, the notice of termination revocation is not happening timely. Final claims are not happening. And then we try to readmit the patient down the road. The NOE is going to be late because the previous benefit period has not been finalized or terminated. And if it's your hospice that created both, in other words, you discharged the patient live, the NOTR didn't happen, you readmit the patient, your NOE is late because the NOTR didn't happen. If that NOTR was your responsibility, your hospice will not get an exception for that NOE being late, therefore causing huge reimbursement issues. So that brings us to the question and answer session. It looks like we only have one question in the queue. If you do have questions, please type those into the Q&A spot at the bottom of your screen. If you hover over it with a mouse, it should come up with the Q&A spot. The question is, if a nurse is ordered, does it have to be a nurse that does the initial telehealth visit? We have therapists with time on their hands and our nurses are swamped. Honestly, I think that it would not be an issue for your therapist to be able to do that initial telehealth visit where they're going to document basically that the patient is going to allow the home health services and assess the immediate patient needs, care needs of the patient, and be able to document that. As of right this moment, if both nursing and therapy are ordered, or nursing is ordered at all, they would have to go into the home and conduct a comprehensive assessment. But I honestly do not see any reason why the therapist would not be able to do that initial review via telehealth. Also, I had someone ask today, while the home health and hospice, I'm going to get it out in a minute, aid supervision has been completely waived during this time period. As you heard me say earlier, CMS is encouraging home health and hospices to still do some type or some level of supervisory via telehealth. And so that may just be, you know, connecting with your patient or your patient's caregiver and ensuring that they have what they need as far as aid care is concerned, and that the home health aides and hospice aides are showing up and that the service they're providing is working out. And the question was, do I think that therapists could do that? Well, as you're all aware, for the most part, the rule stands statutorily that the aides must be supervised by the nurse. The reality is, again, the aid supervision is completely waived during this time period. So there is no regulation for it. It don't exist as far as the requirements concerned. So there's no reason why your therapists that do have some time on their hands, there's no reason why they could not be the one to connect with your patients and document that the satisfaction or lack thereof of the home health aid process and the care the home health aides are providing. So that brings us to the end of the questions. There was only one, but I have answered that. So I want to thank you. I didn't even introduce myself, I don't believe, but I am with Healthcare Provider Solutions co-owner and CEO. We're based in Nashville, Tennessee, but I was set to speak at your annual conference in Oregon that has now been moved, but I will be present at that annual conference. There's a pre-conference scheduled for that annual conference that includes PDGM updates, et cetera, that I will be conducting. So if not before then, I hope to see you at that rescheduled annual conference. And my contact information you see is on the screen. And if you have any additional questions from the webinar today, do not hesitate to let me know. I am also on the staff that will be a part of the 2-day PDGM Summit through the National Association for Home Care and Hospice. I'm not sure that I am speaking on the one on the West Coast, but will be on the staff that does one of those 4 days. Thank you all for participating today, and I do understand that we are deeply appreciative of all of you that are out there on the front lines and are supporting staff that are on the front lines of protecting our nation's health during this emergency. Thank you again, and I hope we will talk again soon.